Okay, well, look, thank you everybody for joining this session on this beautiful sunny day. And I know we've got some amazing speakers, so thank you all in advance. And I also think that we've got the most amazing topic. So not only are we able to come together on a beautiful day, but we're here to discuss perhaps the one thing which has been on everyone's mind in the last few weeks, which is healthcare, COVID-19, and we've got three amazing people to speak. So just very briefly about myself, and then I'm going to do a couple of housekeeping things, and then we can kick it off with who our speakers are. So as for myself, my name is Michelle. I'm delighted to be here. I used to be a clinician myself, but I stopped working on the front line back several years ago when I started working in healthcare consultancy. And now my main interest is looking at healthcare, the healthcare sector all around the world, actually, particularly around artificial intelligence. And I recently wrote a book called Big Brain Revolution, AI Spy or Savior. So a couple of housekeeping things. So please do stay muted unless you get asked to say a question, or you put your hand up in the chat room and you want to say something. Also, this session is being recorded, just to let you know. And also, if you'd like to watch a replay of tonight's event or any other Big Tent digital sessions, then it's one of the exclusive benefits available to Big Tent friends and student friends. So visit the Big Tent website for details, or follow the link in any of the Big Tent emails that have been sent. So as I sort of said, I'm absolutely delighted to have perhaps three of the world experts on the hottest topic in town. So we couldn't get any better. We've got Professor Louise Kenny, who is the Executive Pro-Vice Chancellor of the Faculty of Health and Life Sciences. We've got Dr. Hugh Montgomery, who's a Professor of Intensive Care Medicine at the University College in London. And we've got Dr. Seamus O'Neill, the CEO of the Northern Health Science Alliance. So in terms of other things, we're all got a Twitter handle, so please do tweet us if you want to. I'm going to also be checking my Twitter feed, but let's start with getting, so that the idea is that each of our wonderful guests will say a little bit about themselves and then say something about the topic we're all here to discuss. And then we'll come back together at the end and we'll do some questions. So I suspect that there'll be plenty of people with some pretty big questions tonight. So it's great to start. And I think we're going to start with Louise. So over to you, Louise.
Thank you, Michelle. I'm Louise Kenny, as Michelle said, and I'm the Executive Pro-Vice Chancellor of the Faculty of Health and Life Sciences at Liverpool University. I'm actually a Scouser. I was born in Liverpool and I trained as a doctor in Liverpool. My daytime job, I'm a jobbing obstetrician. I look after women who have complex or high-risk pregnancies. But for the last 2 years, I've been in a leadership position at the university where I trained, in the city where I grew up. And so it was with some trepidation and a huge amount of passion that I embraced tonight's topic, sort of local versus national. And I'd like to start by saying that I think really quite clearly it's not an either or, and it's not a binary choice. There has to be a mixed economy. But for sure, COVID has very painfully, certainly for us in the north, and I'm sure for the whole country, highlighted those areas of public health and healthcare provision within the NHS, which would do better or even flourish under greater local control. And before I illustrate this with a couple of very topical examples, I'd like to firstly issue a health warning, and secondly, some context. So the health warning is that it's really easy to be wise after the event, and what I'm about to say may be very critical, and in a way it probably is. But I'm not for 1 minute pretending I am an expert, certainly in any of the topics that I'm about to speak on. And I'm not certain I would have actually done anything differently if I had been in charge of decision making, 12 or so weeks ago. But I think the point of reflections like this is that we need to learn lessons. We need to remember what this crisis has taught us and not forget, because as we were talking as a group a few minutes ago, we were just reflecting on the fact that in the last 22 or so years, there have been 5 infections with pandemic or actual pandemic potential or have reached pandemic proportions. And that means that once we're on the other side of this, there will likely be another potential pandemic along in the next 4 to 5 years. So that's the health warning. And secondly, the context. There's nothing like a global pandemic to illustrate that we are a global village and that borders are pretty futile. We've heard the mantra repeated over the last 12 weeks that we're all in this together, and we are to a point. But the reality is that in my city, COVID is not treating our society equally, and neither are the measures we're taking to combat it. Even before COVID hit, Liverpool faced a series of very specific and very difficult health challenges. Health outcomes in my city are amongst the worst in the country. Every year, there are about 1,800 premature deaths. A baby girl born in Kensington, Liverpool tonight can expect to live on average 13 fewer years in good health than a baby girl born and raised in Kensington and London. And furthermore, there is huge inequality in my city. If you travel just 20 miles across the Merseyrail network, you will pass through postcodes in which the average life expectancy varies by as much as 12 years. So that massive inequality. And then dealing with all those challenges was difficult enough, and then COVID hit. So what have we learnt so far? So what I think we've learnt in terms of local versus national control of our health care resources is that we are a diverse country, and COVID has certainly exaggerated our diversity. Modelling of the disease in London, which I think in fairness has led to some very London-centric decisions, have national consequences. And they are not always to the benefit of the regions. For example, the pattern of community transmission and hospital admission in Liverpool is very different to what's been seen in London. And I'm not just talking about the time lag. And that means that we haven't experienced a spike, we've experienced a plateau, and our slope to recovery is intensely shallow. And that means that we are now easing out of lockdown at a time when our city is still really in the middle of the battle. And I worry that that decision will mean that we will face a second spike at a time when we are very ill prepared to deal with it. So in terms of local versus national control, I'd like to just finish by illustrating with 2 brief examples where I think local is more important. We've all heard the mantra about data saves lives, data is the new oil, data is incredibly important in actually combating COVID-19, particularly with the test, trace, and treat mantra. But we know from countries in Scandinavia that the level of trust is actually only really possible to be held in a population of about 2 to 3 million people. People are clan. We are a clan-like people. We like to belong to a clan. And once you go beyond that, you lose that level of trust. And so I think national initiatives, including national testing apps, are going to be really problematic. And that's where I think we need to look very carefully at how we actually are networking our data. We in Liverpool have firmly believed that the Connected Healthy Cities model is the best, a sort of federated network of cooperatives where trust is held at the 2 to 3 million population level and data is shared in a pseudo-anonymised way. And I'm sort of out of time, so I'll finish very briefly by just mentioning testing. Testing has been problematic from the get-go in managing this crisis. And I think we're now all aware that had we kept testing capacity at a local level, a regional level, we would have been able to flex and test a lot more efficiently than has actually happened in centralising it. And as a matter of time, I'll pause there, but I'd be happy to revisit that topic during questions. Thank you, Michelle.
Thank you. Wow, that was great, Louise. So that's sort of hit the nail on the head, really, and the fact of what you were describing was the central versus local control. And I love the fact, which I suspect we are going to get questions on later, I love the fact that you spoke about testing and then track and trace, and the fact that you're sort of describing, particularly, you know, when if we disaggregate those things, we've got the track and trace where you sort of described how you've got the 2 to 3 million people where you can build up trust, and the way that you describe testing. And I think that it will come back to some big big questions, which is perhaps for later, regarding how we've done perhaps a top-down sort of testing regime versus a bottom-up localized testing regime. And as a result, we have to question which would have been better, because I think we were all discussing earlier today, is this virus going to go away? Well, not for the foreseeable future. So it's something, so how do we manage it? So that's an absolutely amazing start, Louise. Thank you so much. Let's go to our next speaker, Dr. Hugh Montgomery. Over to you.
Well, again, thank you very much for having me. And I'm going to echo some of the comments we made before, and I'll try to stick to time. So I've got some notes in front of me, which I'll be glancing at. And I'm going to start with central control, working my way down, and the goods and the bads. So in terms of central control, the obvious good in terms of public health was the fact we had a nationally mandated lockdown. We couldn't have left cities, individuals and regions to come up with their own plans. But the downside has been the national lifting of that, which I personally feel was chaotic, the messaging poor, and the results will indeed cause big problems locally. So Liverpool, we've heard, will be in trouble. It never really got the fall off we got, the steep shelf that we've had in London of drops. But equally, we've now got people flooding back onto London Underground, packed in like a penguin colony. And we were likely, therefore, to get a second big spike again. And I think that could have been better managed in terms of national messaging and actually allowing some devolved change in the way things were lifted locally. I echo the views on testing. The national process for testing paralysed the process to do it. The PCR machines that are used for testing for viral RNA were mandated and sequestered in Milton Keynes, preventing local testing when that could easily have been set up. And I certainly know of more than one facility that was set up at scale that could move, that was prevented from doing so because of national control. And I think that was wrong. In terms of the NHS, good. National NHS, nationally controlled, is excellent. It's allowed us a coordinated health response. And it's particularly allowed through our National Institute of Health Research a prioritised research programme. So we haven't had individual hospitals or people running around doing their own small projects. And that's allowed us to get answers quickly. The major trial Recovery is now recruited nearly 9,500 of the required 15,000 due to that national mandate and control. It's allowed us to commandeer private hospitals for NHS use, and it's allowed us to create flexing inability, such as the production of the Nightingale hospitals, which fortunately, very fortunately, we have not yet needed. The bad of that NHS central control, I totally echo what we've just heard. It's been a failure of data integration. By having a failure of national integration, right now when we most needed to be able to interrogate data between hospitals, trusts and regions, we've been unable to do it. And as a consequence, as an intensive care doctor, I can't tell what practice it is that might be beneficial or where I might be failing my patients. And I could do that if I only had access to those data. We should absolutely use the devolved process that we just heard described. PPE, a good thing. Central control meant that there were large amounts of central stocks, and they delivered. And in the first parts of this, that was excellent. The problem was that those civilian supply lines became overwhelmed in time of war, and there was an inability or a paresis in allowing local trusts to do it themselves, to purchase autonomously rather than centrally. And there was also a paresis because some of the PPE issues, protective equipment, actually aren't fit for practice. We don't actually need the levels of protection, in my view, that are mandated, and yet trusts were unable to flex to deliver solutions that actually would have worked quite well. Procurement, good. Central solutions to national problems are excellent if one's got central procurement, but the problems for things like renal replacement therapy is that they're very, very slow. Whilst it allows an equitable distribution of materials, it doesn't allow speed and people being fleet of foot. So that's the central control, good and bad. The autonomous national is good. That's largely been individuals getting together. So without central control, the nation of intensive care doctors, and that's what we're talking about, managed to get together to share information very quickly. Every week we were having national calls of knowledge sharing as we tried to understand this strange new disease and work out how to manage it. We had international knowledge sharing, and we had a process of being able to quickly move from local to national in terms of building new equipment. I was involved with a team that got together on a Tuesday night, and by Friday we had a new machine developed, designed, built and passed for use inside the health service within 4 days. Again, that was autonomous. It wasn't nationally mandated, but it was nationally supported. The bad part of that sort of process is fragmentation. We now face, for instance, a problem with rehabilitation of many thousands of patients who've been through intensive care, who remain gravely debilitated for a number of different reasons. This is a multi-system disease, but there is no central control of that at all. And whilst autonomously different people are trying to get together, it's a fragmented process, and we're failing to deliver for the patients that we should have. And that's partly because of power, it's partly from personality, and it's partly because there is no central funding and commissioning processes take too long. So that's the central control, the autonomous national. The local, the good parts of that means that local control allowed good control. It's allowed us to flex policies, for instance, in renal failure patients getting delivered to different hospitals without a central mandate to do it, which meant that we weren't swamped with such patients. It's allowed us to set in place immediate processes for accommodation. When we suddenly found that we were having to keep our staff day and night, we were able to just do things locally to mean that people could actually have at least somewhere to rest for short periods of time. The bad part of local control is that we lost research capacity, for instance. Every trust was able to deploy its research staff back to the front line, effectively paralysing the opportunity to deliver the research that we required at scale. If that hadn't happened, we probably would know by now what drugs actually worked and would have been able to save far more lives nationally. The same applies to oxygen supplies. Those weren't nationally controlled, and too many machines means the oxygen pressure dropped, and we couldn't actually treat the number of patients potentially that we needed to. We actually mostly got away with that. And finally, because I'm quite sure I must be coming to the end of my time, there are some bits about messaging I think that are worth doing. If one has ill-informed people communicating internally to the ignorant and then representing things poorly, the result is chaos. And I will be critical of the way the messaging was delivered on Sunday night by our Prime Minister. It was muddled, and it meant that people didn't know what was going on. The messages could have been delivered much better locally in ways that people could understand. We've had bad messaging about PPE. We've had bad messaging about testing with swabs that could be much better done. We can come to that further if you'd like some questions. And finally, in terms of local and national and regional, we've now got a government demanding more intensive care beds. In my region, that just being London, that being delivered at scale, but in a way that isn't involving us as the local people delivering that. And I think we may be making some very, very bad mistakes by not engaging the local clinicians, those on the shop floor, effectively. Finally, good things we can come back to. Bonfire of the red tape. It could take us 8 months to get ethics. We were able, in the COVID crisis, to get ethics through within a day. We were able to build ventilators in 3 days. We were able to release national guidance within 3 days of getting together to write it. And we're now back yet again to central control of that process. And the updated guidelines for care that we wrote 3 weeks ago still haven't been passed by NHS England for release. This sort of central control does not help. It slows up dissemination of best practice. So I think I'll stop there. There were other issues I could have touched on had I time, relating to the failure to capitalise on the opportunities related to environmental change, climate change, air quality, and the massive health dividends, oddly, that have come through this crisis, and a failure to learn. We still haven't learned to integrate our data, and we haven't learned how to control lockdowns effectively. And with that, I shall stop. Thank you.
Wow, thank you so much, Hugh. That was amazing. I mean, may I also just sort of add my thanks to both Hugh and to Louise for actually doing sort of this frontline work. And I'm sure that all the clapping, which we'll all do later, we shall also be clapping you all. So thanks very much for a very clear narrative of sort of thinking of putting that in a picture of a global perspective, which is thinking about, well, how on earth, do things like COVID even transmit to humans? And that's thinking about how, how we treat the environment. Then you put it on a very sort of UK-wide, thinking about the messaging that the Prime Minister has done. You then put it on that sort of centralised procurement of PPE, which I think we're going to come back to, and you highlighted a good example of kind of renal dialysis, where we there are certainly there's good and bad of these things. And then you gave the beautiful local example that I suspect may have bypassed some people who perhaps don't have so much sort of frontline knowledge of the what happens when oxygen supplies suddenly drop locally in hospitals, and how do you deal with that when you're on the front line? And obviously that becomes an extremely local issue, which is part of national planning. But so I just covered just about everything you can, and I think there are going to be so many questions for you, Hugh, later, because you've certainly been in the firing line of where we've been at. Right, and our third and final speaker, Dr. Seamus O'Neill, it would be, we're looking forward to hearing from you next.
Thank you, Michelle, and hi everyone out there. It's great to be with you this evening. Yeah, I am indeed Seamus O'Neill. I'm the Chief Executive of this thing called the Northern Health Science Alliance, and I think that following Hugh and Louise, whose roles are very much clear to us and valued by us, I'll probably have to explain a little bit of what we do in terms of context. But I've been the Chief Executive now of this thing called the Northern Health Science Alliance for 8 months. And I'm loving the job of building up what is an alliance of centres of excellence in health, research and innovation across the North. So I'm very much coming from this from the view of what can be done with localism and regionality and buy-in and being close to the population. That's not, as Louise said, this is not a binary thing, central versus local, but there are facets of those two perspectives that are valuable in different situations, and I'm really going to concentrate on the value of localism at whatever scale you choose to accept that. So the membership of the alliance that I am chief executive of is the large NHS trusts, the research intensive universities, and the academic health science networks across the North, and I run a small team of about 8 people who work for them at North of England level. In broad terms, our mission is to unlock the combined potential of those organisations and the North's life sciences assets for the benefit of the North, the region, the people and its economy. So our day job, day in, day out, we support and make visible the excellence in research and innovation that exists across the trusts and the universities, very often pushing that water uphill in a national context and making it visible internationally, where there's an appetite to work with the clinicians and universities of the North and the HSNs as well. That excellence, I do not visibly have a chip on my shoulder, but that excellence is often overlooked at national level. And the pandemic approach politically and operationally has yet again demonstrated that. As Louise said, the effects are disproportionately felt in the North because it is a disease of inequality, a condition of inequality. The effects on the economy will be disproportionately felt here. The recovery will be more sluggish. We know that. So this really matters. There is a levelling up agenda that was very high profile before this particular bomb went off. It's still there, and everything that underpinned it is still there, but it's going to be worse. So our role in the NHSA is to build durable, effective networks across the region and showcase those areas of strength. Now, in doing that, there are some lessons we have learned in very practical operational terms. I've been involved in some very enlightened projects. One was Connected Health Cities, which Louise has alluded to. It was a £20 million project over 4 years funded by the Department of Health and Social Care. It's just published its impact report, and it was a Northern Health Science Alliance project. 20 million sounds like a lot. Over 5 years and 16 million people, it's about 25 pence a year per citizen. So my role in that, I was in my previous role in the North East and North Cumbria was to help set up the Great North Care Record, integrating data and putting up interoperable systems in place and solving problems. Now, we did that with a local mandate and using the practitioners and solving the problems that matter to them. And as Louise has alluded to, in cities like Newcastle and Liverpool and their environs, there are now assets there that would not be there without that, and civic trust that has been built from the ground up by answering questions that matter for safety, for efficiency, and for practitioners to do their job. It's got staff retention and transformation written all over it. It's also got a response to COVID and the public health written all over it. And those networks, you have to build them in the good times so that when the COVIDs of this world hit the fan, when you see a black swan event, you're ready for it, and you've got the systems in place, the trust in place, and the relationships in place to be able to do something about it. Now, the real key here was Department of Health and Social Care gave us the problem, and we distributed the problem amongst clever people. We didn't tell them what to do, and DHSC gave us space to do it properly. There are some enlightened parts of government that can do this and know when to be tight and loose, and that is priceless. The stage gate Gantt chartery of this world is dead. This is a complex system. The answer is not AI. The answer is getting people to work together and building high levels of trust with the citizens. Now, our system is not actually set up to do that at the minute. There's nobody from the north. There's no northern voice on the scientific advisory group. There is no regional voice in the political systems of this either. The devolved nations have a hard enough job getting noticed. So we think there are lessons to be learned in this. The prize is not just how you deal with the next pandemic. I think the prize is how you keep the UK political and social systems together.
Thank you so much, Seamus. That was amazing. I think that you really touched on some quite interesting things. I hadn't actually realised that there was no northern voice in SAGE, so that's an amazing, considering there's like 300 people, I think, in that sort of advisory group. I think that from a housekeeping point of view, it'd be great to get more questions in the chat. I know that I've got some that have been sort of pre-submitted, and I'm going to open those out in a minute. But just to summarise, I suppose, a little bit of what Seamus sort of said, where I feel quite passionate about it as well, is the fact that in some ways, you know, for all the bad and the sad that this pandemic has brought, there is also, you know, the hope that we have to see, I think, for the future, and what's the positivity. And I think that Seamus described, he said it was getting academic excellence it was often like pushing water uphill. That's not sort of something which I think that, you know, we would want to sort of see as UK PLC. There are other countries around the world which are really starting to sort of think, okay, how do we make ourselves fit for the future? Because if COVID doesn't go anywhere, then I guess we're left in a brave new world, and that's, you know, although it might look quite difficult at the moment, it's also an opportunity to make ourselves kind of fit for the future. And there's no reason why the UK shouldn't be the leader of this, because it's got amazing things like academic health science networks, and you know, we've got all of these amazing people in our country who I think are really wanting to make a change for the better. So I think that that's something which may also come up in the questions. So we're going to start while some other questions come in on the chat room. We're going to start with one which I think might go back to perhaps more Louise and Hugh, and it's asked by Alison Bailey, and she asks, Germany's health service has been seen to handle the crisis much better than the UK's. What role might its more decentralized and insurance-based model play in its relative success in handling this COVID-19 crisis so far? And how far should the UK go in following this German system in its model of its own health? So I guess there's two questions there, one around the German health system, and I guess there's also differences in the fact of, you know, is there something that we should learn from Germany, considering we seem to have handled this situation in quite a different way. So I don't know, maybe if Louise and Hugh want to come back perhaps on the German issue.
Well, I'm not actually an expert on the German healthcare system, having never worked there, and there is nothing like working in an alternative healthcare system to give expertise. I do, however, I worked for 12 years in the Irish healthcare system, which is quite different to the NHS. It has a public and a private hybrid system. And whilst it would not claim to have handled COVID-19 perfectly, I think the fundamental difference between how the Republic of Ireland and the UK have handled it is one of size, and it comes back to my previous point. The Republic of Ireland has a population that is of an order of magnitude smaller than the UK at the sort of 3 to 4 million level. And that has meant that they've had an agility and an ability to respond in a way that I think a top-down nationwide control and command structure within the UK has really been problematic. So there are other fundamental differences between Germany and the UK that I am aware of. They have a higher number of doctors per capita. The UK have one of the lowest numbers of doctors per capita in the OECD. They also have a federated healthcare system, which is much more regionally based. So a bit the way I referred to in my opening statement, they have a sort of hybrid model with national control of things like procurement, but a federated aspect to how they run things like public health. And again, that's probably given them the ability to flex responsively to their local environment. Hugh, do you have any other comments? Sadly, I've not worked in Germany, so I don't have the sort of inside track.
Well, yes, I'd like to comment. So the first thing is I'm not convinced that there are any data that say the German healthcare system has coped any better. The mortality rate in intensive care is the same, and the mortality rate for hospital admission is the same. So if you get sick, you don't end up doing any better, as far as the data would show, in the German healthcare system than anywhere else. I think the difference that people might be alluding to is, are they doing better in their way of their public health system and their public policy in containing the spread of the virus? And again, I'd be cautious about drawing conclusions. In Britain, for instance, we tested people with symptoms. We haven't gone out testing the general population. So our denominator of mortality relates to people who are already sick. If between 80 and 96% of people have mild or no symptoms at all, and you're testing those people in Germany, your mortality rate for those people will be dramatically lower, because 80 to 96% of them won't have even got sick enough to get anywhere near a hospital. So the data will be skewed based on that. There are other issues too, the demographics. We have a more obese nation than Germany, for instance. We know that racial and genetic factors matter. And as you've rightly pointed out, issues of poverty and inequity really matter in all of diseases, including this one. And we have a very unequal distribution of wealth in Great Britain, and that will have to play a part. We also have social factors. If you look at London, for instance, we have a very densely packed 10+ million people, with 3.5 million people using public transport every day. And that's a very different situation from German cities, for instance. So we've got to be very cautious about saying that someone else has done better with their healthcare, which I don't think there's evidence for, or their public health policy, which might have differed. And we can come on to whether testing everyone for viral spread using RT-PCR or viral RNA has been beneficial. That probably was something we should have been doing. It's only by knowing how many cases you're getting that you can start calculating the R numbers in terms of spread, and that might have led to policy change in terms of lockdown, and that's something where I think they did do better.
So what's it? I know that we've got lots and lots of questions now which are coming in on chat. So let's start by asking John Clemo to ask his question. Over to you, John.
So my question was around wider system links with non-NHS providers. And so essentially it was, to what extent do you think centralised approaches enable or disable links with providers such as our district council colleagues, local resilience forums, social care providers, community pharmacy, and from my own perspective, voluntary community and social enterprise organisations?
So I think we can illustrate this with testing, and I'd like to go back to this topic because I ran out of time, and I think Hugh did touch on it. So I think the whole issue of testing illustrates how local stakeholders were removed at a very early stage in the process from being able to support the rollout of what I think would have been a much more effective approach to testing. So as Hugh mentioned, the platforms, the PCR platforms on which we perform the antigen testing, the diagnosis of COVID-19, there are a limited number of those platforms, and they were actually requisitioned by central government at a very early stage in this process. My university had 3 of those platforms, and we were preparing to use them to expand our local testing capacity when they were collected by the army and removed to Milton Keynes for distribution to the Lighthouse laboratories. At the time, there was some anxiety locally about sending those platforms, but it certainly seemed to be a very widely supported and reasonably well organised process. Certainly they were, within about 12 hours of them being requisitioned, they were collected by the army and they were gone. Unfortunately, what that actually as a university meant was that the capacity that we would have had to support our local NHS, as we frequently do, in ramping up local capacity for testing from about 800 tests a day to about 5,000 had gone because our platforms were gone. Despite the fact that we actually had at the time a limited amount of consumables and also 180 members of our staff who were eminently well skilled and trained and could have supported that testing. So it's a perfect example of how local stakeholders, all the ones you've mentioned, plus the HEI sector, were really disenfranchised from a decision, from a very high level decision that was very centralised, to sort of reinvent the wheel and invent a sort of centralised approach to testing. And inevitably, I mean, you know, PCR it's not particularly complex, but it's not straightforward. Particularly of a small labile virus, an RNA virus, and inevitably setting up brand new laboratories on brownfield sites in 3 central locations, even with the full weight of the army behind you and huge amount of expertise and input, it's a very complex procedure. And so I don't think it surprised anybody who had the inside track or inside knowledge on that testing became a bit of a hot potato at a very early stage. And we're still living with that consequence now.
So I echo Louise's comments on that. That was our experience too. Central London has the relevant, as indeed Louise's facilities do, the relevant levels of containment to deal with a dangerous virus. That is an important thing. As Louise says, to try to build biological containment facilities with appropriate staff and expertise where those don't exist is a major logistic infrastructure problem, let alone transferring the swabs from where they're taken to those central sites when actually they could have been done locally. So I think that was an error. I think to pick up on some of your other points about engagement more locally, yes, I agree. I think what's required actually for quite a lot of process now is a permission for local trusts or boards or regions to act in the best interest of their patient with a budget that will devolve down. People are not wastrels. They often know what the local capacity is. There are lots of voluntary groups, as you've just mentioned, the questioner mentioned, stepping up to the plate to deal with everything from accommodation and food for staff through to rehabilitation services and assessment, and indeed testing. And being hampered by national regulation does prevent that engagement to a significant degree. In fact, if central government would do anything, it might be helpful to just provide a little bit of financial and personnel lubrication to help bridge the hospital sites themselves that are overwhelmed with the local voluntary organisations or other that can help and are so willing to do.
Well, thank you.
Yeah,
go on, Seamus.
I think that's a really important point with very significant implications. In that the expertise to do this, and this is a fairly dramatic circumstance, and that's not always the best case law. But the requisitioning of equipment nationally, but the tendency to in a much more subtle setting, the tendency to go nuclear with control is damaging long term. It's damaging long term to the breadth of experience and the breadth of input you get from community and voluntary sectors to the social care sector. The lack of input is damaging because it narrows the breadth of ideas and expertise and opinion that is there at the table. That's not healthy long term. The second bit is that it chips away at the trust and chips away at the involvement. One of the great themes that runs through the big tent is participative democracy. That's a recurring theme of these discussions about, and it's part of the aspiration of this discussive forum, and that participative democracy relies on participation and it relies on conversations about whatever it is. Now, the more that you fail to do that, the less engaged people become in civic enterprise, and the less trust they have in the process long term, and that is dangerous. I think in principle, you should do it locally where it is possible, not just snap back into the, we know what's best.
Thank you, Seamus. Well, I like the fact you're talking engagement and community, because we've got more engagement from our many people that are watching us live. So Don Boyd, over to you next. If you can unmute yourself and then mute yourself again after the question, that would be great. Over to Don.
Hi, I'm muted. Absolutely brilliant to hear all three speakers saying what they've been saying about the participation of local as opposed to national. I wondered what, my question was more precise when I wrote it out, what the flaws in the process that we've discovered over the last 2 or 3 disastrous months, what those flaws in the political system might, in the national sense, destroy the ability for us to involve local and global people in the search for a vaccine. So what are the problems that have been hampering there's no such a thing as a perfect setup, but what are the problems that we've learnt that can disappear away from the national initiative and involve the local initiative and global initiative in finding a virus, in finding some solution to the virus. Apologies for the slightly weird way of asking this question.
Not a problem. So again, this comes with a slight health warning, and I'm not a vaccine specialist, but I do lead a faculty that has a centre for vaccine research, and I think my colleagues would be very keen for me to share with tonight's audience that this crisis has forged international links at a size and speed and scale that previously we've never seen. So, and I think Hugh touched on this before in terms of how we've pivoted as a healthcare community to do things at a speed and with an agility that we could only dream of during peacetime. So I think, and that's regardless of any political system or any local control. The academic community globally have united. All former alliances, battles, competition has been forgotten, left in the gutter. And the vaccine community are, in essence, working as one. It may sometimes not seem like that when you have these big announcements that one university has had a breakthrough and it's forging ahead with, you know, the latest vaccine. But the sad reality is, as I understand it, that the search for a vaccine is not going to be short. It's going to be long. It's going to be complicated, and it may not be successful. And I think all of those specialists working within the vaccine research community are working really unencumbered by academic affiliations, by formal rivalries, and all the normal motivation that would stimulate academic pursuit or medical research. They are pretty much one big global family right now, searching for what I think actually may sadly be quite elusive. Hugh, do you want to add to that?
I don't know what you say. So I think to deal with the vaccines issue, I don't think there have been substantial barriers. I totally agree with Louise. Making vaccines is really very, very difficult, and coronaviruses are very, very tricky indeed. And bear in mind that there are 7 that affect humans, one of which is the common cold, and a lot of money has gone into trying to crack that one over the years because it would be very lucrative, and it's failed. So this is very complicated, and I don't see that there have been barriers to vaccine development. In terms of drugs, I also agree with Louise. Drug companies got together incredibly quickly in an agnostic way to say we will work together to screen compounds and try to get stuff out there that works, independent of who owns the rights to those or where the commercial realities of return might lie. So the Glaxos, the Pfizers, and the AstraZenecas of the world got together to form a consortium to screen compounds and get them out double quick. And that's been terrific to see as well. There have, I think, been some problems, and I would go back to the ones that Louise mentioned earlier and I echoed too, and that is issues of data, research capacity and biobanking. We've been talking for a very long time nationally about being able to link data. Honestly, we could crack an awful lot if we could just see the electronic data stored within trusts and link them to sample analysis. And we haven't got that infrastructure there, and we really should put it in place. If we'd had that, with the UK's tremendous facilities for biological research and computational biology linked to those, we really could have got on top of this disease in terms of some of the fundamental biology very quickly. So I'd like to see data linkage, and I'd like to see better biobanking storage. And finally, was this issue of message, you're saying lessons learned, the fact that our research infrastructure was not defended from the tidal wave of cases that came in. And I work in a trust, I totally understand it when we had one nurse looking after 6 intensive care patients, that you pull in anyone you can with a clinical background to help support that. I get it. But in the longer term, it's not the most efficient way to do things. If we'd recruited every single patient into the trial, we probably would have caught all 15,000 for recovery, and we'd know what drug worked by now, and a lot more lives would be saved. So lessons learned, let's defend our critical research infrastructure better, get better data linkage, and get it linked to biobanking.
Seamus, I don't know, do you want to...
No, I don't know. I think we'll keep the conversation going. I think the guys have handled that beautifully.
That's good, we all agree. Okay, the next question should be from Sonia. So over to Sonia to ask your question.
Hello, yeah, thank you everyone for a really interesting discussion so far. I think we've covered quite a lot of really important insight on what the challenges are and also some examples of what's worked well, but I think we've had more examples of what's worked well at a national level despite all the critique and challenges than we have at the local level. And in light of lessons learned and what we can take away in terms of better preparedness for future potential pandemics or crises of this nature, what has been happening that's good in your local NHS that we may be able to scale up and sustain post-crisis? Thank you.
So maybe I could start with that. So so in Liverpool, we at a very early stage pivoted our local healthcare partnerships. So that's all the NHS trusts on our patch, and there are a lot in Liverpool. We've quite a fragmented NHS offer with what was 2 acute adult trusts and is now happily 1, but 6 specialist trusts, so a huge number of trusts who belong to our healthcare partnership. We pivoted all of those trusts and the 2 main HEIs who are active in infectious diseases research, that's ourselves and the Liverpool Tropical School of Medicine, into a new sort of goal command type structure, which we call Liverpool Stop COVID, which I actually chair. And we created this incredibly flexible, responsive system with a gold, silver and bronze command with operational pieces on the ground, and gold command overseeing the governance. And we did that mainly mainly because we had to. We in Liverpool lack significant NIHR infrastructure. We don't have a biomedical research centre or an academic health science centre. So we, in the space of a week, tried to recreate that infrastructure and the governance and framework that would have given us. What it actually allowed us to do, and what we are very keen to retain if peacetime comes again, is actually, unlike what happened in London and Hugh's experiences, we were actually able to retain our research capacity within the NHS. So the majority, not all, but the majority of our NHS partners have actually managed to not pull back research nurses to frontline care, because we had some warning and because we flagged that the fourth pillar of how we were going to get out of this mess was through high quality research. And working with our chief execs, because they were well sighted on what was coming down the track and what the need was, they've managed to retain that research capacity. It's also given us an amazing agility to do things that actually are well outside of my remit. So I'm a clinical academic. My job is to make sure that we do, fantastic education and research. I never for 1 minute imagined that I would turn into a small engineering manufacturing plant making PPE. But within the first week, when we got our Department of Engineering actually saw some code to 3D print elements of PPE, including full face visors, we went into wholesale production of PPE for our NHS partners. So we learned that we could do things as an ecosystem. that we would never have imagined even attempting, you know, during the pre-COVID era. So that creativity, that flexibility, that cohesiveness, the structure that we've created out of necessity that we didn't have before this, that's something that I am desperate to retain in the new normal, whatever that may look like, because it's given us a newfound cohesiveness and a closeness and an ability of a fragmented health ecosystem to respond as one. And it's also, you know, out of adversity comes great things. It's made us creative, it's made us flexible, it's made us imaginative, and it's made us passionate about what we're doing on our patch. You know, as I said before, we're all in it together, but we really do feel that in Liverpool, we're all in it together as a city.
Louise, I'll pick up on that as well. So I'd echo everything you said. We had exactly the same experience. We needed to design new CPAP circuits. We went to our engineers and we designed new systems within a few days, working with the university partners. We would manage the same with testing if we've not got stopped. Ethics was tremendous. You're much younger than I am, but we've probably both been through cycles of being told that ethics is going to be streamlined, made more efficient, made England a powerhouse for helping industry work with us. And every single level of this just paralyzes us further. And we are now slower and more up to our necks in ethics than we've ever been before. And that disappeared with this. Things were still completely ethical. They were reviewed by ethics boards and decided to be so. But if it can happen in 30 minutes in the middle of a crisis, surely it shouldn't take 8 months the rest of the time. And we're reverting right back to that now. We are back to the same sorts of processes. Again, localism, not being trusted to produce stuff. The national guidelines I alluded to earlier on, we were trusted as a group of experts within the profession to produce national guidelines. We did, and they were cleared within 3 days. Now they're having to be going through a process of central review by people who know less about it than we do. And that 3 weeks later, we can't get them out. So let's get rid of some of this nonsense of road blocking and checking and process that really isn't necessary. The other things, I totally agree with the flexing. We were able to move people between jobs without worry about governance. And orthopods were able to turn into proning teams. Dental receptionists were able to turn into intensive care nurses. And they could, and they did. And if we allow people to step up to the plate, they perform exceptionally well. When we stop people stepping up to the plate, we deprive them of the opportunity to grow, and we deprive ourselves of a really rich resource that can support us all the way through. And furthermore, we've learned that by trapping our juniors in red tape and training and limiting their hours, actually most juniors would like to work longer, not shorter hours, by preventing them working in teams as we do, and by making them fill in endless paperwork, they're demoralized. And it's why a third of junior doctors leave after only a year of having been trained. That's reversed. The level of enthusiasm we've had amongst our junior staff has been extraordinary. The morale has been fantastic. And I can tell you now, there are some trusts in London where the juniors are refusing to go back to the training and the rotas they had before, because they've now got a taste of what can be done when they're liberated from box ticking and can engage in a team to deliver excellent clinical care. So we've learned that too, and I really would like to see that retained as well.
Look, that is right, absolutely where I'm in this, the learning from this whole thing. So the need to pay proper attention to the soft stuff in the cross-organizational networks, the kind of networks that have really stepped up here, the critical care networks across regions, the ex-nurse networks out there, and that have come back, and the ex-medic networks that have come back to work. All those sort of social networks have been absolutely invaluable in this, and the priceless sort of soft stuff that has been mobilized here is forgotten about and actually dampened down by central control. And that balance, it's a duality, okay, but that balance has been wrong. And it's been wrong to the extent that it's created huge inefficiencies in the narrative of taxpayer value for money. It has created such inefficiencies as are legendary in the NHS about the inability to do things. What Hugh's just described, taking 10 weeks instead of sort of overnight approval, and the difference that makes to efficiencies. A trust setting up a manufacturing plant for something it needs in a matter of weeks. You know, those are the sorts of things. That's the innovation that is in the public sector that is latent. It's not even latent. It's suppressed. Now we need to retain that. We need to find a way to correct that balance. And I'm going to be probably I'm going to get in trouble for this one, but it's people who don't know what you're doing telling you what to do that's the problem. The lack of trust in the system and the lack of expertise. Let's call it the Fauci effect. You know, what Tony Fauci is trying to do here is get expertise to the political table, and it's not being listened to. And that's missing. There's a bit too big a gap between the policy and the politicians and the practitioners. We've seen that become that has been breached, that gap, by local activity across the diagnostic and therapeutic and the practical stuff like supply chains. It's been phenomenal, but the centre has been 3 weeks behind the experts.
Can I just chip in there again with one more example? That was excellent, and you reminded me of something else in this issue of professionalism. Professionals, by definition, are prepared to act outside their remit and take responsibility. As far as I'm concerned, I'm happy to take responsibility, and if I get it wrong, I'll pay the price for doing it. And I'm very glad to do that. We were running the issue with low oxygen pressures. I contacted colleagues in the oil industry. They're able to supply 18 divers at 21 atmospheres with over 200 litres of gas a minute. So supplying the oxygen levels we required in hospital was peanuts for them. But that was refused because apparently the oxygen that you breathe at 21 atmospheres in the North Sea isn't medical grade oxygen. It doesn't seem to be poisonous, and you can breathe it at 21 times atmospheric pressure, but that wasn't fit for being breathed by a patient. And furthermore, we were told that they couldn't do it because there was an explosion risk. And I tried to point out that they were dealing with oxygen at 21 atmospheres next to flammable oil and gas. The people who are most experienced in the world in stopping that sort of accident happening would be oil engineers. And we could have deployed them. The oil industry would have deployed within days, but they were prevented from doing so. Fortunately, we got away without needing it. But it's another example where we should free people up to take responsibility for their actions, I think. I'm happy to take liability for my own actions. I'm sure others would be too. And I'd like to see a liberation of such responsibility.
Thank you. Wow. So I think we have to make this the last question. It was great to hear like liberation of localism there, and not just talking about, actually medics, but actually thinking about how you cut red tape, you kind of just get things through ethical committee because it's the right thing to do, and you bring in lots of other disciplines. And there's some great examples there with which we should all be super proud. So the final question should be from Freddie. And if I can just ask the speakers to also make it their kind of summary as well. So try and sort of do 2 in 1, because I know that we could speak for all evening, but we have to make this the final round. So over to you, Freddie.
Hi, thanks very much for the opportunity. My question was, I work for a charity and we're looking at thinking ahead to services getting back to normal or a new normal in the NHS for our patient group. What do you think the role of national bodies like NHS England should be in leading us out of this crisis and getting services back to normal? And what do you think the role of local health systems should be, particularly concerned about existing inequalities and differences in services across the country being compounded, basically? Thank you.
Thanks, Freddie. So I think I will probably finish by going back to where I started from. So I think the role of the NHS is in treating this disease, and actually our new normal, if our new normal is to be a normal that we all want and want to embrace, then we need to prevent this disease, and prevention is the remit of public health system. We're quite passionate about public health in Liverpool. We have one of the first public health chief medical officer, William Henry Duncan, who was appointed, post-Irish famine. And we've had a long and illustrious history of it. And it's been quite depressing, I think, over the last 10, 15 years to see how Public Health England has been systematically defunded, underfunded, and reconstructed and tinkered with, such that when this pandemic hit, it was not best placed to deal with it from a public health perspective. In the absence of a vaccine, and I'm normally a very optimistic person, but for a variety of reasons, I think we should not pin our hopes on a vaccine coming anytime soon. In the absence of a vaccine, then this virus will continue to circulate. It will continue to wreak havoc. It will continue to have disproportional effects on a regional basis, particularly in areas like Liverpool, which have a hidden morbidity anyway. And therefore, it is absolutely intrinsically important that we actually have a bolstered local public health system for for testing and tracing. The tenets of public health, the basic tenets of public health, are what will help us manage this outbreak in the longer term. And public health is best done regionally, because we're all one village. We have no borders in a pandemic, but this disease has actually exaggerated the differences that we have within our country. We are a diverse people with very diverse health needs, diverse health outcomes. And public health is local. It's based on trust, it's based on local knowledge, and it's based on local resource. And so what I would like to see coming out of this is a recognition that we need to invest significantly in public health and get it back to where it used to be. The countries, as Hugh said, we suspect as medics that the countries that have done better haven't done better because they're any better at managing the consequences, the medical consequences of this virus. It's a horrible disease. It wreaks havoc, and we're treating it with the same drugs, whether you're in Germany or the UK or Ireland. But those countries that will get back to the new normal faster are those countries with really efficient public health systems, where they've invested and where they've got that running like a well-oiled machine. And we're an island nation. We've got many advantages. So we should be able to pivot to a public health system with adequate resource that helps us get on top of this. But that's going to require investment at a regional level, and it's going to require regional voices to be heard.
Thank you. I'll jump in there. So I have to say, Louise says so many things that I would say as well. The first thing I would say is, let's, in the issue of what we do locally compared to nationally, let's let government nationally set destinations, not routes. I think it's perfectly reasonable to say what the expectation is for delivery and preservation of health, but it will be different in Liverpool from North London and from North London to Central. And I think let's let localism decide what the route to the destination is, because they're often much better at determining it. Secondly, I could not agree more. The National Health Service is not a national health service. It is a national disease treatment service. And if outside COVID, you came to my intensive care unit on any day of the week, 14 out of 15 patients in those beds on a smaller unit are there due to public health failure. They're due to lack of exercise, poor diet, lack of access to clean air, poor education, drugs and alcohol, all of the things that are affected by poverty and iniquity. And if you sorted those things out, you could sack me and get rid of me, because I wouldn't have very many patients at all to deal with. And the same is still true of COVID. It is not hitting people equally. It is hitting the poor most for a bunch of reasons, including their comorbidities. So I absolutely would be reinvesting heavily in public health. And I would take that in a much more broad fashion. And I would include the environment. The fact that 176 people were boarding a jet plane every second around this world was a recipe for spreading a virus around the world. And it's not like we didn't see it with SARS-1 or with MERS either. It's just this got a higher R value that's made it more lethal. So we've got to start thinking more broadly about the way we treat our planet, how we manage our food, what our taxation policy is to protect our environment upon which we depend, because bear in mind, we all die from climate change for the next 60 or 70 years anyway if we don't get this right, and then start protecting public health as a priority rather than very expensive high-tech care at the far end. And finally, you said as a summing up, I mean, I would say a huge thank you. And I think the thank you goes not just to my health worker colleagues, the nurses in particular, that step up to the plate, and are the frontline workers outside that support us all. But my thanks to the general public who've lost their jobs, who've borne that with tolerance. I'm paid to do a job I enjoy, and they have none. I'd say a big thank you to the people of the country for responding to lockdown as they did. If they had not responded, we would have been absolutely swamped. That's why Nightingale was being built, because people didn't think the British public would respond as valiantly as they did. So massive thank you to them. And actually, picking up on Louise's point from the beginning, I will say a thank you to our political leaders. They may have their failings, may have made mistakes along the way, but I don't doubt that whatever the party political colour of people in charge, that they were trying their best to do the right thing. They may have got it wrong for a bunch of different reasons, and that's much easier to point to in retrospect. So I think we should just remember that no matter what the party politics, they've had a pretty tough war as well. So a thanks to everybody for that.
Okay, just to draw a few of those threads together, I think this has been, the learning of this is a public health issue in the broadest sense. Now, legend has it that 80% of everybody's health is economically driven and 20% on the healthcare that they receive. Now, we're focusing in this pandemic on the really acute stuff and the really sort of high intensity medicine. The effects of this go all the way back to the economy and life chances and, social circumstances, jobs, environment, proximity, travel and all the rest. I think we got to start attending to the really unsexy stuff at the end of this. And it's got to be, the instead of the acute medicine end of it. It has been denuded. Local authorities have been trashed in their funding, and they cannot do what they need to do. I think it's time to get back to some of the really unsexy stuff. The local versus national bit, we've got to do something about that. The social contract here is at risk of being dismantled. The trust that people have in the systems, and the lockdown and the response has been great, but we need to rebuild that social contract in some way. And participative democracy and participation in the systems of government has got to be part of that. I think it's a much bigger issue, and there's far more at stake here than just the healthcare system. I think it's a far bigger issue. Hugh's mentioned the environmental aspects, and we need to retain some of the good stuff we've got in that one, the wins we've had. And the answer for me to that one is not more control and more centralisation. It isn't even more coordination. It's about trust, and it's about stitching society back together again. Now, if there's a long haul in anything, it's that.
Thank you so much. Well, look, that I think brings us to a close. So I would personally like to, I know that people can't really clap, but I'm going to clap to say thank you so much to Hugh, Seamus, Louise, and of course to the Big Tent, and to our amazing people that have put up many lovely comments. So thank you all. They're all very well deserved for our three speakers. Just as a reminder, if you want to watch a replay of tonight's event or any other Big Tent digital session, it's one of the benefits available to Big Tent friends and student friends. So do visit the Big Tent website for details, or follow the link to any of the Big Tent email. And I guess you all mentioned sort of localism, and I guess there's the local sort of sociable side of being online. So I'd like to thank everybody for joining in, and I think that although now the session has come to an end, that some of the people are going to be around for the next half an hour or so, or 20 minutes, or a little while anyway, so we can get to hear a little bit more about their thoughts. And it's been a huge honor that all of our panelists have given up some time tonight, because it's the one thing that everybody wants to hear, and you've given us it's just been a joy to hear you all. So thank you all very much.